Welcome to our Kaleidoscope Live. We are the Kaleidoscope team from the British Journal of Psychiatry. And each month, as you might know if you've been here before, we talk about some papers that we found interesting in the scientific literature, which we've published in the British Journal of Psychiatry. We have a couple of interesting papers this month, one on antidepressants and one on COVID vaccines to keep things topical. So the first one I'm going to open up with everyone on antidepressants, and it's a paper from the New England Journal of Medicine. It's a paper by Gemma Lewis and all from UCL, and it's looking at stopping antidepressants in primary care. So this was interesting to me. I picked this for a couple of reasons. So the first thing is, there's a really common question. Some of you will have taken antidepressants before, might be taking them now. And if you recover and you've been taking antidepressants, there's an obvious question: am I well because I'm well, or am I well because my antidepressants are keeping me well? What should I do? And so at a population level, with 1,000 people, we know that keeping people on antidepressants tends to overall keep people well longer. They have fewer episodes of relapse. When they do become unwell, it doesn't last as long. But you can still become unwell even if you're on antidepressants. It's a bit like asthma to me. If you take your asthma medications, you might still have an asthma attack, but medications help keep people well. But for an individual, the question still comes up: what should I do? And should I stay on them or should I come off? And it was interesting to me because it was in primary care. So lots of research on antidepressants tends to occur in quite specialist settings in universities with atypical samples of people. So not real world setting. 90% of antidepressants are prescribed in primary care. So that's kind of interesting to me. It's in a more naturalistic real world setting. And the other thing that struck me with it, it taps into really contemporary debates about antidepressants and medication more generally. And some of the current things that people talk about are: is there too much medicine? Are we putting too many people on antidepressants? And the number of antidepressant prescriptions has increased in the last few years, last 10 years or so. Although the counter to that is, if you look at the data, it's generally because people are being kept on antidepressants for appropriate periods of time in line with guidance, whereas beforehand they used to be taken off them quite early. And the other interesting area for me at the moment is the issue of deprescribing, which is quite contemporary. Recognizing that for some people, coming off antidepressants can actually be quite a difficult thing, and some people will have withdrawal symptoms from the medication. So antidepressants, staying on them, stopping them, it's really important, and primary care is the place to look. So this particular study, it's a UK-based study, and they got 150 GP practices, and they randomized patients within it. So the patients in GP practices had had at least 2 episodes of depression. They'd been unwell for at least 2 years, but at the point of entering the trial, they felt well. So history of depression, significant history of depression, on tablets, currently feeling well. So therefore the question is, do I stop them or do I continue them? And they were randomized, so the patients didn't know, they was double-blinded. They were either continued on their antidepressant or they put on a placebo that discontinued the antidepressant over a period of time. So the person taking the tablet didn't know if they were staying on them or if they were not staying on them. And the primary outcome was what happens a year later. And so the data showed, and maybe this won't shock people in a sense, but the antidepressants worked. So people who stayed on the antidepressants did better than those who came off them. Those who came off them had a higher rate of relapse. But we'll probably go into with the rest of the team here is talking about the detail of what that meant. So the kind of headline figures were that 39% of those who stayed on their antidepressants relapsed by a year. 56% of those who discontinued. So you could also argue, is the difference that big? So that's my kind of introduction to it. I'm going to pass over. Who wants to take this up? What did you find interesting about the paper?
I'm happy to add a few comments. Really, I think it's a really phenomenal study in the sense it's such a difficult question to answer, that to really be able to finish a study, recruit appropriately according to their kind of power calculation, and to have a relatively clear primary hypothesis that you're going to say, well, here's how we're going to define becoming worse. Here's a kind of relapse if you score above this for this period of time, if you have these symptoms. And then to have a relatively clear analysis which says, do you fulfill that kind of relapse criteria earlier if if you are withdrawing from medication versus if you continue on that. And the answer, I think, is clearly yes, you're at greater risk of having a relapse if you discontinue medication. So I think that bit is really reasonably clear. And then there are a series of secondary outcomes, which they're at pains to say that these are not corrected for kind of multiple comparisons. I mean, Dan can correct me if I'm wrong, but they're saying these are additional bits of information that you can take into account. And on most of the parameters they looked at in terms of withdrawal symptoms, general well-being, and so on, that the people in the withdrawal group tended to have more symptoms and have a lower quality of life and have more kind of withdrawal symptoms than the folk on the other arm, as you might anticipate. But they're keen to say that you can't read too much into that secondary data. I think with all of these things, because people feel strongly about whether this is how much you can generalize the results of this. So this study suffers from the same questions in the sense that the people who came into the study, there were like almost 25,000 people who were invited into the study, but actually only 500 people actually made it all the way through to the cut. So how is that a representative sample? Then if you look at the detail of it, they're in their mid-50s, most of them, and they are, 95% of them are reported as white, and 75% of the women. So this particular, the idea that people are happy to come into they're keen to stop their antidepressants, but they're happy to come into a trial to do that, is automatically a kind of, you've got a kind of slight selection bias of people who are relatively, I would argue, might be kind of open to the idea of continuing medication for a bit, but they look like to enter the study, you want to be interested in the question. So I think if you're being critical about that, and I'm sure some people will be, then one of the issues is about how representative will this be for a general person that you or I might see in clinic who's been on medication, feels reasonably well, has been on it for a year or two, and actually is thinking, do I really need to be on this? And I'm getting some side effects or not. And then the final thing that I wanted to just mention was really around that there is, they chose a kind of fixed regime of withdrawal over a couple of months or so. And so one of the bits of data that's been out there is this kind of concept of, is that efficient enough? So if you just reduce the dose by half every fixed time interval, is that, you can understand that it's easy enough to do as a dose. You have 20 milligrams of a drug, and then you might do that for a couple of weeks, and you might give 10 for a couple of weeks, and then 5, and then you might stop it. But there's certain data suggesting that that kind of dropping at that rate is not you don't see that same kind of linear effect in its effect on receptors in the brain. That actually you might need to be using much, much smaller doses towards the tail end of the withdrawal than you might at the beginning, because the way it binds to the receptors is not as a direct function of the dose. So they describe this kind of hyperbolic process, and that you need to account for that. And their suggestion is to fix that, is to use ever smaller amounts of medication as you get towards the end over a long period of time. So I think what this study has done is it's tried to cover a kind of relatively long period of time. It's not tried to stop them in 2 weeks or something. It's kind of saying we're doing it over 2 to 3 months. So I think that bit is ticked. But the slight doubt for somebody who may be critical of the study will be about, could we have tailored that withdrawal regime to reflect this slightly different action on receptors that that's been reported?
I'd like to jump in from a slightly different angle, which I think echoes some of the wonderful comments we're seeing. So thank you for those. I looked at this as the non-clinician of the group here. I looked at this and went, this is an amazing study. This is great. I like this for all the reasons that we've already discussed. And I'm left with no better clarity as a regular person in this world trying to advise my friends and my family about the choices they have in their life, about what actually is the best choice. And I think that it highlights a gap that we often see in the literature. But some of these comments were kind of around the gut feeling I had about the study, which was that this is great and this tells us something and we need to follow this up more thoroughly. But it's clear to me that all people taking antidepressants through a GP are not the same group. So within this space, we've got some nice aggregate data, and that's great. But actually, we obviously need to be following up with some further distinctions amongst these populations. And I see this from the comments here, whether it be genetic or clinical history or whatever. But I think I walked away a little bit sheepish, because I don't know, while I know this contributes to the knowledge base and the literature and will be a springboard for many things in the future, I don't feel like I can go and talk to my people in this circumstance with much better information. So can you guys, as clinicians, can you speak to that?
Stan's cue. So you're going to change your practice, Dan?
And I read this paper and then read all of the attention that it got in the media, and found myself finding it hard to disagree with any one of the perspectives in here. But to speak to some of the questions that are coming up, there's a lot of questions coming up on the chat here. There's a number of things that this study was designed with a primary outcome to measure relapse. And they defined what relapse is as far as they are concerned for the purpose of the study. And it's retrospective assessment by the patient on a modified version of the standard questionnaire. So you see a patient at 12 weeks and you say, in the last 2 weeks, how have you been? And then they have to tick a few of these boxes. That's the best you can hope for with an RCT conducted at the population levels. This is a multi-center study. It wasn't just one specialist clinic, which is, I think, what we're all more used to with regards to pharmacology studies. Although granted, the phase 2-3 stuff tends to be in multi-centers. But so I think, the things that this paper should be congratulated for are that it's in primary care, which is where most of the prescribing of the specific drugs they study takes place, right? In terms of tailoring so a separate question I think to that is, should you tailor the discontinuation schedule? The taper should be tailored for individual patients, because we know that withdrawal effects are idiosyncratic, and we know that relapse is also idiosyncratic. So there's perhaps my argument here is if you were going to study with an RCT at this scale, this phenomenon in primary care, this primary outcome is the best I think you could expect. If you want to study how to best taper or how to best withdraw, then you need to do that in secondary care with clinicians that have the resource available to them to closely monitor that. So I remember from my clinical work, a lot of what we do is deprescribing. It's that patients come to the end of a period of treatment, usually defined by them as, I'm prepared to have engaged with the treatment for this period of time. I would like to stop, sertraline, for example. And then we're lucky we've got the resources to follow them up, right? We can see them for half an hour to an hour at a time. We're able to schedule events, for example, a review after 2 weeks or 4 weeks. We're able to request that they're prescribed liquid formulations of some drugs, so that we're able to help them taper in a hyperbolic way, as Sukhi mentioned. So that level of attention to the withdrawal schedule or the taper schedule is something that GPs don't have the luxury of. So that's my point, I think, is that if you're going to do this at the population level in primary care, this primary outcome, as it's defined, shows that you get the results that they got. And I think that's all you can generalize from. They're very cautious in their limitations about how you generalize this. So I think that's to be commended. So does it change what I do in practice? I think the answer is probably not very much. And that's not a failing of the paper. That speaks to the benefits I enjoy working in secondary care, where our job is to very carefully deal with problems of discontinuation and withdrawal syndrome. So there's my answer, Dawn. Sorry, it wasn't a very specific one, but that's how I feel about it.
It's not really interesting, because I was thinking about that question from Dawn too. Does it change my practice? And I think no, it probably doesn't. And then, so this is a big paper, New England Journal of Medicine, one of the biggest journals in the world. Everyone's talking about it. Are we getting excited about what they did? So they did a trial in primary care. And is it actually going to change clinicians' practice in that way? So what's the utility of the paper? Why is everyone so excited? So it is interesting what they did. I think it's been a huge piece of work. So I'm going to let you guys think about it. I'm just going to pick a couple of questions that people have put in. So Sissy has asked about, could it be that those who are on placebo did badly due to antidepressant withdrawal? And there's a counter to that. So the idea is, could you be blinded? There's a thing called nocebo effect. So might you know what was happening? So one is, if you're randomized in a trial, and then you start coming off your medication, maybe you start to feel worse, and that's what you think is happening. The other thing that could happen is whether or not you detect side effects that you ordinarily get from your antidepressants. So if your antidepressant makes you feel maybe tired or gives you dry mouth and dry eyes, and you suddenly feel that that's not happening, then maybe you'll know what's going on. So there is a challenge to this paper, which has been picked up, that maybe the blinding is impacted by people feeling either side effects or lack of side effects, or from them having withdrawals. I don't know if you've got thoughts on that.
And I think they look at extra parameters. They look at side effects within the study in their secondary outcomes. And on the whole, it looks like the people who are withdrawing have a higher level of side effects reported. So, and clearly it's difficult to disentangle that you feel worse because you're having side effects from this particular kind of design. Because as Den said, it's primarily answering one question, which is, in primary care, if you withdraw medication over a 3-month period, are you more likely to relapse than if you continue taking that medication? So it answers that question, but like any good study, it raises several more. And I think there are a few questions in the panel asking about, are there more, how well were the patients matched at baseline? Is it that one group were more severe or had been ill for much longer? And I think the authors have made a good attempt to say that at baseline, when they randomized them, that actually there's no huge differences between the two groups in terms of the ones who withdraw or not. I guess one of the things that struck me was the fact that actually even in the maintenance group, even in the people who continued taking medication for a year, that actually almost 4 out of 10 of them suffered a relapse on these criteria. And then when you read the detail of the paper, you can see that a significant proportion of both groups, like up to 40% in the withdrawal group, actually went back on, went to see their GP and then were put back on antidepressants. So I think the bigger issue is that even if you're taking medication, it looks like the chances of suffering a relapse are actually quite significant. And that clearly can't be laid at the door of either withdrawal or antidepressants. And so it may well be that these are things that within the chat, people are asking a little bit around what other input did people have? Like normally you might be offered psychological work or psychological therapy to complement your antidepressant, or now social prescribing is more becoming more fashionable, and whether that may be something that may be helpful for either the people who are withdrawing, but also maybe even for the people who are thinking about withdrawing. And the other thing I found slightly perplexing about the paper was really about that they mentioned kind of how many people, how adherent people were with the kind of medication regime or the withdrawal regime. And there were quite high figures in terms of the numbers who were non-adherent with that. So I think that makes it a little bit more difficult to interpret the final findings.
I think to follow that point, Sukhi, I think what you can say is that actually there was significantly less, and I say significant in the sense of it seems clinically relevant, significant, that in the adherence was much worse in the tapering group, the people who were being withdrawn. So even though they were blinded to the fact that their dose had been halved for a month, for example, there was less adherence there. So I think that probably gives us a clue that there is some signal in whether it's relapse, whether it's withdrawal, there is some evident distress that makes people less likely to concord with a treatment plan, however you construe treatment plan. Yeah. So there's obviously problems being caused by reduction of antidepressant dose. Yeah, you can certainly say that because the adherence was lower, the DESS scale was higher. Yeah, and the reported relapses were higher in the discontinuation group. So I think what it tells you is there is something going on. How you disentangle them, I think, has to be answered by a separate study, which looks specifically at tapering, how you taper in an individual way to counter the fact that withdrawal syndrome appears to have an idiosyncratic component. It's very hard to predict who will and who won't experience the more severe end of withdrawal syndrome. So I think given those things, you need another study, and that study has to look at careful, tailored tapering and withdrawal regimes. I think that's to answer that question, you have to do that study. I appreciate they put it as a secondary outcome for this, which I think is admirable and really worthwhile doing. But I think it's a very different study to looking at primary care prescribing of a handful of antidepressants that are most commonly used in primary care. So that's citalopram, fluoxetine, sertraline, and then mirtazapine. And they're not identical in terms of how I would taper sertraline differently from mirtazapine, for example. So, I think that's the point. You need that study, and it needs to be done, and it will be a worthwhile and interesting piece of work. But I think it's a much more resource-intensive study as well, because GPs don't have any time at all with their patients, whereas we benefit from having a lot more time to be able to do this in an informed, tailored, and precise way.
It's interesting. Sorry, go ahead.
Sorry, just a small comment to add to that is that I kind of think, when you're specifying a further study to try and clarify individual kind of variability. So one of the questions is that we know that the fluoxetine has a much longer half-life. So your prediction might be that the tapering from that, actually, the effect might last a month or two beyond, even after you've stopped that. So that might be an interesting thing to look at. I see Louise has raised the point about the entry criteria. Some of them, people maybe have been on antidepressants for a couple of years. Others may have been at higher risk of relapse from having 2 relapses previously. So actually, are they compatible? Are they you're comparing apples with oranges? So I think all of those questions are fodder for future studies, which are going to need to be powered, and the questions will need to be addressed slightly differently.
Yeah, I thought it was interesting. It's been picked up by lots of people in the chat. And hello, we got someone from Chile joining us, which is great to see. You're very welcome. But I think people are picking up the variation. So on the one hand, at the start of this, we talked about, isn't it nice that this is real world? This is a naturalistic experiment in primary care, because we never do that. We tend to have very rigid randomized control trials of very idealized samples of people. And that's the reason we do that people smarter than me, but do really good randomized. By doing that naturalistic trial, it's all the things that are coming up in the chat. It's true. So we've got very different groups of people. So different periods of time on medication, lots of variability between them. They do try control for that, and they do discuss the 2 groups, those on discontinuance. But I think it's absolutely right. So this is the challenge of doing that type of study. Another theme that's coming through is about, I suppose, messaging to primary care. So there's a question about who are we, but we're 3 psychiatrists and 1 psychologist. So we're also an unusual group of people. We're quite strange in some ways. So what would the learning be for primary care? And following on from that, is there a lesson from primary care about deprescribing? And this is, I'm asking this in a way the answer is yes, but is there a lesson for GPs about deprescribing and also having more informed conversations with people?
There's quite a nice comment from Jane there, who says that she works as a GP and is essentially saying that most of the people that she sees won't be referred to secondary care, and that there is resource to be able to see people, to be able to monitor the withdrawal. So I guess actually the points that Dan was raising may only be relevant. It may well be that this data is suggesting that you can withdraw. So if the lesson is you can withdraw people cautiously from medication, as long as they understand that the risk is enhanced of having a relapse. And actually, it may then be that if they do relapse and that's a problematic state, that maybe those are the ones where you might think, actually, you might want to refer them to secondary care. I'm not saying this is the thing to do, but I'm saying it raises the option of then doing it in a slightly different way or a slightly more cautious way, or adopting this hyperbolic tapering regime for those people who it's been problematic to actually withdraw them in the kind of using this standard regime.
I think Luis actually posted a comment that bridges really nicely to our second article, mentioned one of the inclusion criteria on this first paper about emphasizing personal empowerment and people taking control and responsibility of their decisions into consideration. So shall we move?
Great segue. So we're going to hand this over to Dan. We're going to talk about COVID vaccinations. We're all vaccinated here. I'm particularly interested in any comments or questions from anyone in the audience who has not been vaccinated, because the paper is about encouraging it. So what's the paper, Dan? It's from Nature, right?
Yeah, it's a paper that last month in Nature by Duffy L, and it's looking at, in the Californian health system, whether or not you can persuade people to get their first vaccine dose. The way they did this was to use principles from nudging, so subtle behavioral interventions that persuade people without being preachy, without being didactic and telling them what to do. And the idea, as I understand it, comes all the way back from 2008 with Taylor and Sunstein's book, Nudge, which kind of proposed this new way of helping society manage problematic behaviors, or not just problematic behaviors, but encouraging positive behaviors by not being didactic and giving them things that subtly persuaded them that they should do the right thing. So, and again, my reading of the literature on nudging is that it's been pretty roundly panned since the publication of that book in 2008. It's not had an easy ride. And I think scientifically, a lot of the empirical data that the kind of look at me studies that really seem to demonstrate perhaps the power of nudges started to fade when people started to expose the flaws in those studies, which range from just sloppy design or sloppy analysis through to outright fraud. So the whole field has taken a hammering. Anyway, what they did with this study was to try and nudge people by doing the following. Roughly speaking, they had a control arm, which was just people who were eligible for their vaccine, and they did nothing. They didn't prompt or get in touch with them. Then you had another group of about 18,000 people where they sent them a text message. The text message just said, "You're due your vaccine," or words to that effect. I'm paraphrasing. Then they sent another group of 18,000. They gave them a text message which was phrased to encourage ownership of the vaccine, which is, "You have been selected for your vaccine. It is now available. You should come claim it now." So the language was very different. And then they did exactly the same text messaging again, but in another 18,000, where they used the boring text message with a video, an informational video. And then they gave them the ownership, the nudge text message with the video as well. So you've got kind of 5 groups going on here. The headline summary of the paper is that in the text messaging group alone, so where you just sent them a text, 12% of people who received the text went and booked their first vaccine within a month. And in the text message, but where the phrase was, where there was an ownership theme to the text message, 14% roughly went to get their first vaccine within a month. So purely at the statistical level, there was a demarcated difference between the responses. Interestingly, the video, no matter whether the video was added to the ownership text message or just the bland text message, made absolutely no difference at all. So here's what they concluded here. If you take those small effects in what is about 90,000 people overall, if you take those small effects and you multiply it by the number of people in the US, Duffy et al. Estimate that you would get between 1.4 and 1.7 million more people getting their first dose of vaccination by using this nudge method, which is a text message which contains a clear ownership angle. Yeah, it's your vaccine. You are now eligible for it. You should come claim it. So that's their conclusion. The peculiar thing about the study is they did an online survey. using exactly the same ideas. And then they asked people to say, now, having been exposed to these interventions, are you likely to go and book your vaccine? So sort of intention to vaccinate. Yeah. And they found the opposite. They found that the nudging intervention made no difference, but the video did. So that, I mean, that's slightly confusing, but they interpreted it as in the actual RCT, the actual nudge intervention study, that only 21% of people who were sent the video actually looked at it. So they're arguing that you can't draw much in the way of conclusions from that. So that was the finding. I find it hard to criticize this study. It seems, they said what they did what they did. They got what you'd predict from a nudge, which is a modest effect size. And the reason it's interesting is because, it's modest effect sizes, but when you scale it to the population level, it's impressive. 1.4 million people vaccinated, more people vaccinated rather, would be an outcome, right? That's impressive. So listen, I thought it was interesting because given the panning and the hard time that nudge has had over the last 12, 13 years, it's kind of interesting to see some people having a go at it again, having the courage to have a go at it again, and more impressively, particularly in a field like COVID vaccine hesitancy. That's my conclusion.
I'd love to jump in because I think, number one, what we've learned is that even though we know about spam and we know about all kinds of nasty things coming through the internet, 1 in 5 people still clicked on the video, right? I wouldn't click on a video link that was in my random text message. So
unless it comes from Maudsley Learning.
Yeah, exactly. Always click. But other than that, that's a really interesting thing that actually there's multiple things we're fighting. And one of them is that we're leery of being phished in different ways, shape, or forms. But I think, so there's nudge in this very specific kind of behavioral health intervention space. And to be fair, why not? Like, let's look at all the tools at our disposal. We know from pure behaviorism that we as humans are susceptible to this kind of thing. If we're reinforced at a right interval of time, then we will see behavior increase. Not 100% and not every single time, but we will see an overall population level effect. But what I think is interesting is we can say this is rubbish or of limited value in so many ways, but actually this is the basis of marketing. When you were talking about something about you and you, I was thinking, I can't even remember where it was for, but there was an advertising campaign for a university, a higher education institution. They called itself the University of You. And it was so, you could imagine it being in some sort of dystopian movie in the future. But we do with this all the time, and we fall prey to this all the time. And so why not sort of look at ways we can harness it for public health and public good? And then my second, very separate point is, and I feel like I can say this as an American from California, this is a particularly American paper because there are whole chunks of the world that are desperate to have access to a vaccine. And the idea that we would be fussed about 2% of some group who may or may not want to do it because maybe they just want an extra reminder on their phone, all of that sort of dissolves when you actually look at greater world demand. And while it is important to look at the ways in which we can increase vaccine uptake for broad public health, of course, I just wanted to point out, because I don't think anybody else is allowed to say that out loud, but I do think there's a very American bend to this.
We talked before, there's a different kaleidoscope where we're looking at adhering to COVID rules and wearing face masks. And we had that study on tight and loose societies, as they were phrased at the time. So following societal norms. So one suspects there's huge variation between societies. There's an interesting question here that struck me too. So Schuyler Matheson talks about it's more difficult to get people to do healthy things, to nudge them the right way. And I've wondered about that too, if it's easier to nudge people away from it. So there's Wendy Hagan mentions about schools and protests, and someone else has mentioned about there being protests. I live in East London, and there's a local school here where if somehow people infiltrated the school IT system and got out #fake news about the COVID vaccine. It was very well done. It had NHS heading on it. But if you spent a little bit of time to dissuade, to nudge people away from the vaccine, and I've no evidence from this, but I wonder if it's easier to nudge people away from it. Sukhi, do you have any thoughts on it?
I mean, firstly, in the chat, I've seen there's a comment by Kristen who talks about the experience in Cambodia, where clearly people are actually, so this is at odds with what Dawn was saying, that there's whole swathes of places in the world where people want COVID vaccines, where she describes the experience that actually people weren't very keen to have the COVID vaccines at all, and the uptake was relatively low until lots and lots of people started getting COVID and the hospitals became full, when suddenly the view changed that maybe it may be a good thing. So I kind of think that it's difficult to generalize. And again, coming back to Dan's point about our first paper, this is really, it's answering a specific question. And I think there are two things, I guess, that I'd like to point out. I guess the first one is that sending a reminder, and they're saying that they're looking, the reminder is really about ease of use. So they're putting a link in your, whatever they're sending you. So if you want to just book in, just click here. So you don't have to negotiate a website, you don't have to sign in, you can basically just click and that takes you through. And just doing that almost doubles your kind of the number of people who sign up to have an appointment and the number of people who have a vaccination. So for me, this struck a chord with kind of with a little bit around social prescribing, a little bit about trying to encourage people towards eating healthier, exercising more. That it's well established, I think, that the easier you make it, the more obstacles you remove towards people taking up those kind of activities, the more likely they are to A, take them up, and B, sustain them. And that's one of the things that they talk about, that once people had their first vaccine, that actually the vast majority of them, I think 80-90% of them, went back for the second one. The second thing that I quite enjoyed was, I mean, they talk about, you know, the one factor is about ownership versus kind of just sending a boring message. And the way they did ownership was exactly as Dawn said, that it said, claim your vaccine, right? Your vaccine is ready for you now. Claim your dose before things go, which I thought in a way is quite, you know, it's such a simple way that you're actually directing it towards somebody. But actually, if it has the effect of tuning things by 1 or 2%, then actually clearly it works. And that's exactly the point about marketing. So, you know, whether you're going to click on something or not, but the way to get people interested seems to be that if you can focus it and get their attention and make them feel like it's something special, then that clearly will increase the uptake. And their kind of key messages at the end, which just reiterating what Dan said, was essentially ease of access improves take up and ownership, and possibly having an information option increases ownership. The discrepancy with their Mechanical Turk, which I think is a fantastic name for online kind of software to do large studies, and the fact that that's discrepant with that, I think that really does actually need a little bit more thought. So it's fine to say that only 21% of the people took up the option of seeing the video, but what you want to know is, in that 21%, their data are large enough. Do you see a differential effect or not? And clearly somebody must have asked that question. So I'm not sure that that's reflected in that or not.
Also mentioned taking away obstacles, but there's a comment from Lana, and a few other people have mentioned this too, about obstacles in the way that if you don't get vaccinated, so if you don't have a vaccine in some countries, I know if I go back to Ireland, you don't get into restaurants, bars, hotels, that in a way society is also putting up other barriers to non-vaccinated people. And there's a comment from having a second one and talked about autonomy over their own body. And it's interesting in the sense that this is one of the big debates about vaccination programs, in the sense that there is an argument about an individual's autonomy over their own well-being and health. And then there's also a wider debate when there are vaccinations that we impact each other too. So with the fact that we can pass on infections, it becomes quite complicated. But I do think there are nudges in the other way. I find the difference between talking about cultural differences in countries, Ireland and the UK, they're so close. And again, the differences that push vaccination rates, I think, are the fact it's much harder to go around in Ireland without a vaccine if you don't have a vaccine passport and they check it.
That's interesting. I think there's two comments in the chat that follow up on this, and I thought that they were really super interesting. The first one was that that nudges seem to be culturally specific, and I think that's probably true. I think that may be one of the grand take homes from 10 years of nudge bashing, is that you can't generalize. You can't write a book that says nudging is a generic principle built into each and every one of us, that when we all share it, we can all be nudged, which I think some of us might find a bit patronizing anyway. But the idea of being culturally specific, I think, is completely brilliant. And there's a comment that I'm trying to find in the chat. I think it was for Anastasia, who describes living in Greece, and who says that there was, when the vaccine was available, no one was kind of keen to take it until they started saying you need to pay for it, and everyone rushed to get the vaccine after that, sort of suggesting that if something's free, it's not very good. Which I thought, I mean, that's striking. That I really like that as an example of a, you could argue making, introducing a fee for something is kind of a nudge, right? It's like, get it before it's too late. I don't know what that says about any particular culture. I'm going to hold back on commenting on that, but it's interesting. I think that's a really interesting point. They have to be designed to be culturally sensitive and specific.
So I'm going to let Laura throw the final question to everyone, because it's really topical. It's on forced vaccinations. I put a link in the chat. You might have seen it was announced today that from April, all NHS staff will have to have vaccinations if they're going to work, all clinically facing frontline. And some of you may be frontline NHS staff, so I'm curious of your opinions on that. The counter argument would be, so if I say I'm not interested in washing my hands, I'm not allowed to practice. So why might it be different if I say I don't want to have a COVID vaccine and work in frontline healthcare? So are any of you against this, against the forced vaccination of NHS staff? It essentially won't be forced vaccination, but you won't be allowed to work if you don't have it. Any comments on forced vaccinations more widely?
I think my comment is that this isn't new. We just think it's new. I couldn't attend school without showing my vaccination card. I couldn't enroll in university without showing my vaccination card. So at least within the US, this is something that we have done, prioritizing public health above our own individual freedoms, knowing that there actually is a choice in there. You can choose to not get these vaccinations, and then you choose to not go to this institution. So maybe I've just sort of been acculturated in that way, but I don't think this is new. I think this is the same stuff, but in a modern context.
I feel a bit like someone's pulled a pin on a hand grenade and is handing it around each one of us. And we're waiting for the end of the podcast. None of us says it's going to affect anyone.
Yeah, I'm seeing if I can get any of you to say anything controversial before the end. But I think as healthcare folk, I think people are going to be vaccinated on the panel, I guess. Well, okay, we'll use that to draw it to a close. That's been a really great chat. We've really enjoyed having the questions from everyone and so many people from different parts of the world. Please come back again next month. We'd love to see you. So have a great evening. It's been nice to talk to you all.
Bye.
Thanks so much. Bye.